Hello, colleagues. Today we have our webinar focused on an advanced use of OccluSense. I think OccluSense is a fantastic technology. I take this issue near me, chairside, every day, and it's very useful for me in my daily practice, every day. As you know, Bausch is an old company that we know from the university and that provide for us fantastic skills to check occlusion. Every one of us know the occlusal papers of Bausch of different thickness, obviously. Well, we today can use occlusal papers from 200 microns until 4 microns. But is this enough to check occlusal forces of our occlusion of our patients? I think not, because today we can use a new skill, a new instrument that can allow us to measure the forces. And if you have a value, a number about forces, your opinion became science. This is the company in German, and this is the area in which they have courses for our colleagues. About occlusion, we have to remember that the contact into the arches is not a static issue. It's not only static, because it's the dynamic occlusion that can create and damage our work, our restoration, or the teeth of the patient. So we have to check static occlusion, but also the dynamic contacts into the teeth in the lateral sided movement or in the anterior movement. So the lateral guidance create forces that we have to check and manage. If we don't manage forces, we cannot prevent the lack of success. So actually, my current standard is to use occlusal paper in different thickness, but also to check with an electronic instrument that it OccluSense the quantity of forces. This is an example also of different colors to check the movement and not only the static points of contacts into the teeth. As you can see in the movie, we usually in our daily practice use different colors to mark the different situation in occlusion. So you can use different color for the anterior and posterior contacts and for anterior and lateral guidance. I can tell you that in my daily practice, I prefer to use only 2 colors. I start immediately to record and mark the lateral and anterior movement with the red color, and then I superimpose and overlap the dark color, black or blue, to mark the static point of contact. So for me, 2 colors are enough. But if you want to be really accurate, you can use until 4 colors, as shown in the video. And this is in my practice, are my occlusal papers, because I prefer to use an elevate thickness to mark the principal contact. If you use the 200 microns thickness of occlusal paper, you can check also the importance of forces, but obviously to be accurate, you need a little thickness until 12 microns, 8 microns, 4 microns, okay? So if we look at occlusion, we can see some sign of excess of load. In the anterior part, you can see anterior teeth abraxed, because in this situation we have an anterior envelope and the forces are strong and they can damage and grind progressively the teeth. In particular, if you are with a patient that have problem of neck, headache of neck for trauma, for example, well, his jaw will try to find some space in the anterior area of the mouth and will damage with an overload anterior teeth. So if you look at this, or you have anterior envelope for dental occlusion, or it's possible also you have problem of neck pain and the jaw try to find a more anterior position. It's possible also to see lack of vertical dimension or some interference in lateral guidance. Here you can see on the screen an interference by this metal ceramic veneer crown, and you see that in the lateral sided left movement is not only canine or canine and premolar guidance, but also a precocity of contact in the movement, not static, marked by the red signs here on the ceramic. This is overload for me. The same sign, red sign, here on the wisdom tooth, because frequently it creates precocity of contact and damage the freedom of movement of the jaw. This is not good for the correct balance of the occlusion and for an harmonic activity of levator muscle. Well, but here we can see only point of contact. How many is strong this interference? No, it's not possible to know with the occlusal papers, because our instrument can show us a difference into the low pressure and high pressure level of the point of contacts, and also can show us if there is a difference in the contact of area, because the green area show me a large area of contact, topical for abraxed teeth in bruxist, and with the yellow color you can see a smaller area of contact, and the red color on the red columns show us punctual contact, that mean high level of pressure in a little area, so risk of crack on your ceramic veneer, for example. And you can see in the picture that those colors and those bars colored can help us to know the level of pressure on the full arch. And we can see if this pressure is perfectly balanced, or if I have some area in which I have an excess of load. And the colors help us also to see where is the excess of load, anterior or posterior areas of the arch, or left or right in the arch. Is immediate, easy, fast. Remember, you have a scale of colors from the red to the green. So we have the possibility to see if the pressure change from the low level to the high level, or the opposite, obviously. OccluSense is handy, obviously, fast. The sensors are really thin, because only 65 microns of thickness. We can use 2 different sensors, because the wide sensor is 77 millimeters wide, and this is useful for us because frequently we have some large arches. It captures 256 level of pressures, so it's an important number of levels. And as I told you, it's thin and is really flexible. This is really important, because the structure that support the sensors is on paper, so it doesn't interfere on the cheek or on the tongue. It's very comfortable. It's flexible, it's not hard. And the color of the sensor mark the teeth. So the color is coating on the teeth, and this helps us to see immediately where is the market area. Just a fast resume of the system, very fast. My assistants in my clinic prepare it for me because it's very easy. It's not possible to have a mistake and have a mistaken positioning of the sensor in the handle. Then you only have to position it in the mouth and ask the patient to close strongly the mouth or to move the teeth on left, right, anterior, posterior. If you only record the static position, the static context, you need only 4 or 5 seconds for a fast check. If you need to check the lateral sided movement and anterior movement, you need 15 seconds or 20 seconds. It depends on the ability of the patient also. And then you can see and record the different moments of the video in which you see each single contact. Because my question is, where is the first contact? Where is the precocity? Before that the patient assess occlusion and find the total contacts on the total arch. Well, obviously remember to position correctly the sensor in the center of the arch with the red arrow in the middle line of the upper arch. You can see in the video, you can check also lateral sided movement. This is important to control if you have a pure canning guidance or a group guidance or a balanced movement, left or right guided. For example, for a prosthodontic, removable prosthodontic treatment, okay? Obviously, OccluSense cannot replace the articulation papers. OccluSense integrated. And in my practice, the first thing that I did in the past was to check occlusion with papers or more thin foils. Remember, with paper, you cannot see the first contact, initial contact, because occlusion will slide into the maximal intercuspation. And you can see only the final intercuspation with a big number of contacts, but which is the first? The precocity that allow the patient to move it. So it's not enough to have a static pictures of occlusion. Occlusion, I told you, is dynamic. So I need a movie to check occlusion. A movie that record initial contact, the slide into intercuspation, and the final maximum intercuspal position. And this movie integrate perfectly my occlusal paper. Why? Because, for example, during the dynamic movement, and if you want, you can check also the chewing. It's possible I have different structure in my mouth or in the mouth of the patient, obviously, and the ability of the structure of a crown on a fixture to support the overload is different than the possibility of a natural tooth. So I prefer to check the importance, the value of the forces, because I have to check if a fixture have an excess of load. you can see in this radio two different structures as in the video. In the premolar, I have a teeth on ceramic and metal on a fixture. Obviously, the strong is different. The forces are different. Also, the system to fix the crown need a screw inclinated, tilted. Is so more important to check forces. And really, on my crown, the forces are high level and punctual. This is dangerous for my work and for the health of the patient, but it's not possible to see it as in the picture, only using a 200 paper or thickness of the paper. Because if I use the occlusal paper, I see a good contact in the entire arch. So this is the precocity that I don't want to see. I have to check it. I need to find it and to correct it. I love this case because it's an example of a dangerous situation that can be managed controlling the forces. This is a bruxist patient, obviously, that need a composite only on his tooth. He lost the feeling. We know how to do a restoration of these teeth. A tabletop on the teeth is possible to do it. We know the rules. We can prepare it respecting the correct protocol for the indirect adhesive restorations. The restoration technique is common for us. And also the availability today of a scanning of the arches that is very accurate, that can show us also where are the point of contacts. But I prefer to help my technician to design the restoration well integrated in the movement of the patient and or in the movement of the jaw of the patient, integrated in the control of forces. So in this situation, I prefer to check and record the real movement of the patient. So I allow my technician to design for me a restoration that is perfectly balanced because respect the real movement of the patient. So my restoration will not interfere on the movement and will not be too much loaded from the occlusal forces. Is this allowed for me? Usually it's possible, but in this patient, the situation is dangerous. I risk a crack. So I fix the restoration of the tooth. I check with occlusal paper, obviously, and I correct it with a gum because there is a really little mistake, a really need of correction. But also is important to check the forces on the tooth. You can see I prefer to use my instrument chair side because really is every time is available for me. Each patient is his proper sensor really to use. And the 20 seconds, I use this number of seconds to check the movements. And in the lower part of the screen, you can see anterior movements that don't create interference in the posterior area. So immediate anterior disclusion and the lateral disclusion without interference. So right, pure canine guidance, and left canine and premolar guidance. It's okay. Or is really a strange situation to see a pure canine guidance in a bruxist that abraxed and damaged all the arch. So a good function, easy to preview, but important to check, obviously. So choose the correct number of seconds for each exam. frequently I try to not exaggerate the number of seconds to don't use an excess of memory on my iPad. Overload is you have to find overload, you have to evidence it. And it's important to prevent the hinder of damage caused. Here you can see, for example, the risk for this tooth. Me and my partner, we don't like to extract the teeth. We prefer to save them. We try to save also the cracked teeth. And frequently, a good restoration can help us to allow the patient save the teeth for many, many years. But it's not possible to do that without to control the occlusal forces. It's important to control it. It's not enough to check it with occlusal paper, absolutely, because this is fragile, a fragile tooth, but it can do its work for years and years. But sometimes it's not possible to save, obviously, the tooth, because if it's cracker until the root, you have to extract it, but you have to be worried about this area, because it's not enough to position a perfect fixture. It's not enough to have a perfect scanning of the arch. In this area, the same forces that damaged the tooth can damage also the restoration on the fixture. So if you don't check the forces, your new restoration can be damaged. You can see here the excess of load on the posterior area and the correct distribution of the forces on the splint. It means that this patient create an excess of posterior load is not depending from occlusion, depending from the activity of her muscles. So my partner and me also use a microscope anti-200 magnification to check the effect of overload on the ceramic and on the teeth. And this is very impressive. So learn that it's important to be worried about overload. I am a neonatologist. Usually my patient overloads. They have an excess of load, an excess of contraction. So for me, is really essential. But I think that to check the forces is essential for every one of us, for every dentist that works in the mouth. The excess of load can obviously be important not only in bruxist, but for example, after an important trauma. You can see here a fracture. And also in people that practice sport, you can see this lady, she's very, very strong. We are checking her forces with this halter system, and we can see that when she do exercises, she grind and clench very, very strong. Is 4, 5, or 10 times more strong than usual people. So is not useful to, it's important to avoid overload, checking forces. And what about bruxism? Actually, bruxism, as Manfredini tell in this paper, is not a pathological phenomenon. It's not really parafunctional. Bruxism is physiologic for many, many people. Is not associated usually with pathology, is not capable to harm stomatognatic system. So the patient can brux, is allowed to brux, but we have to manage those important forces. And in these studies of Dr. Farella, you can see his picture is. Those are the slides of Dr. Farella from Australia. He published with important authors, Ambra Bichelotti, Dr. Cioffi, and he found that usually people, if you position a precocity of contact on its teeth, usually the people don't clench. We have a marked reduction of the frequency and intensity of the contraction episodes in if you have an excess of load on a teeth. But this don't is not the same phenomenon that you can find in patients who have an history of TMD or parafunctions. So the patient who have TMD or pain or problem of TMJ, well, they don't have this reduction of intensity of load. They load also if they have pain. So the TMD patients are really dangerous for our work and are my usual patients. And for me, it's mandatory to check forces also with OccluSense. Let's see together some case report. This is a social player, so really, really strong. We check players in different situations, and we can see that they are strong. They can damage the splint in this area, and also this athlete also damage the second molar, the right second molar, in the same area of the splint. So it's really hard to protect athletes from their big strongness. Because during the sport activity, they exercise a big muscular contraction in all their body and in the mouth, obviously, also. So we check the splint with occlusal paper. As I told you, movement with red signs and static with blue or black points, you can see the different mark on the splint that show you where you have to touch the splint is different if I have the interference in lateral anterior movement or a not correct and balanced load in static position, but also the report of OccluSense show us that we can check the real forces and we can see both the situation, the occlusal points and the movement of the jaw with forces. So using the OccluSense, we can see if I have an excess of load in some part of the arch or the splint. Then we check it with occlusal paper, and after, again, we check if the forces are balanced. Balanced forces mean that I can have so much of point of contact, each of the contact is low level, not just a small number of contacts with high level forces. And for our athletes, it's evident I have an excess of load on the second molar. And also an analysis of muscular activity with electromyography show me the same situation. Excess of load on the posterior right area from the masseter. The right masseter works more than the right. So create this excess of load that I can record with OccluSense. So also for me is important also for legal reasons, because I can show to the patient that is not my work that is overloaded, but is his muscle that work in not balanced situation. And to manage the splint, well, it's useful to manage the splint using also OccluSense. You can see this situation is a good mouth of a strong young patient, but is osteopathies tell me, I have a problem with your splint. Now is old and abraxas, and I don't like the effect on the posture. He check the posture, he check the spine, and tell me, you have to correct the splint. Aye. It's not easy to do that because I am not a direct relationship into occlusion and posture, but something related is. So I check with the splint with OccluSense, and I immediately see an excess of load on the right part of the splint. I cannot see this overload with occlusal paper. You can see the balance of the splint don't show me a difference in the right and left area of the splint. But I know the splint on the right area is abraxed, here is no more balanced, and the occlusal forces are different in right and side in the left side. So I need to repair it, and it's possible there is this relationship. It's possible there is a relationship in posture, for example, not only in the papers published, but also if you see a patient and you can see that, for example, this patient create an excess of work of the left masseter only turning the head. The head rotation create an excess of work of the left masseter. For our young patient that I showed you, there is a problem. He tell me, when I do my motocross activity, I grind when I jump, and when I grind, I see that I cannot position correctly my feet on the platform because I have a problem with the right foot on the platform. And the osteopathist told me that it's the splint. I don't know if it's the splint, but I prefer to balance it. We check it with electromyography. We see a difference into right and left side of the muscular activity. So I prefer the patient start to chew something that create a training for muscle, because I prefer this activity is balanced left and right. Then we modify the splint, some sable to create a round surface, some resin, and after a preparation from the osteopathist, we ask the patient to close and mark the new position. So I don't change the splint, I only repair it and balance. Then I finish the splint with my cutters. The first cutter is obviously raw to remove the maximal part of the resin. In the posterior area, I prefer not to have any interference in lateral disclusion. So I use the cutter horizontal, as in the video. I can accelerate to show you as I use the cutter in the posterior area. I suggest you don't to create an excess of intercuspation in posterior area. Flat and point of contact, because the guidance are anterior. Is more easy for us and more easy for the muscle of the patient. Sorry. You can accelerate just a little. A more thin cutter to finish and polish. Some space for the tongue, and then again for the finishing. We have not the time to see all the video, so I have to go faster. Well, the final result show me a little excess of load over there, but a more balanced activity of the splint. And the patient can jump with his motocross. Another splint. I today want to show you some splints. This splint is damaged from the patient. A very strong woman, you see, is a boxer. It damaged it here. And you can see also the topical teeth of a grinding patient with some area of precocity or excess of load. I think there is an excess of load here, but I'm not sure. It's possible to protect the side guides on the splint with some composite. You have to prepare this the lateral canine area, preparing a little thickness to position some composite. I use some sable to have a rolled and adhesive surface. Then we can position on these areas some bonding and composite. This little trick can allow you to protect the posterior area of the splint because the composite is more hard to abrax from the patient, and the splint will stand well balanced for years. Obviously, you will have to balance it with our usual attitude with the cutter and occlusal paper, red and blue. And I want to obtain only pure caning guidance because it's more easy to manage, more comfortable. And then we check the splint with OccluSense, because this good balancing, I think, have to show me also a good distribution of forces on the entire splint. And this is good. And for the patient, the lateral disclusion is correct and comfortable. Also, the dynamic check, left and right, to show me on the right side a different situation that I see on the papers, because the patient create some a distribution of loads in the lateral guidance on a big area of the splint. On the left side, I have a good lateral guidance, but with an interference in the opposite side. So I need to see and check where is this interference. Another clinical case that we prepared with my partner and friend in my daily practice, and a fantastic osteopathist that is Giacomo Squini and physio from the Stomatological Institute of Milano. For a patient that is in open bite with important posterior forces, is really interesting to see the importance of posterior areas that damaged the molar is corrected, but also another important information. In the past, were not an open bite anterior, because those teeth are grinded together. They abraxed each other, but in the past, actually, they don't touch. So something is happening. Our osteopathist told us that there is an excess of posterior load because it's the tongue of the patient that pull on the teeth, and also an interference, an extraoral interference from the neck. So the patient have an excess of posterior load, and the shimstock only touch on the second molar. and also the lateral sided movement overload the tooth. So the tooth is cracked and to be changed. It's not possible to save the tooth. This is the situation. Not good, very dangerous. So you can see here the infection. This is the situation. So today we are focused on occlusion. This is a bad occlusion, dangerous. If the patient is anxious, grinned and cracked the tooth. It depends from the neck. I think yes, from the neck. Is the neck and the tongue that create the open splint, the open bite. So we prepare for the patient the splint that distributes the load in the entire arch to save the other teeth, because the cracked teeth had to be extracted. But we need a more balanced occlusion, and also electromyography show us that there is a more balanced occlusion, the forces are more distributed. Well, if you come to ski in Italy, you can see our mountains. Another interesting case report, a very simple approach on a patient for which a colleague asked me, please help me to find a new position because I cannot prepare therapeutic prosthodontic plane in this position. We have a deep bite with damaged teeth and an insufficient vertical dimension, and also the OccluSense report show us an excess of anterior load and a low posterior contact or absence of posterior contact. Well, it's very easy on a patient that is not dysfunctional or parafunctional to record a new position using only a wax. You can work on digital situation, but also on traditional situation. You can use a hard wax to prepare a basis, and then you can position some soft wax to record the design of the teeth. You can use also some aluvax if you prefer to mark perfectly the position of the teeth on the wax, and then you can record the habitual occlusion of the patient without to force it in a position that is not natural for the patient. I prefer to record the usual more comfortable position for the patient. If I don't like it, I ask to me why the position is not correct. It depends on a bad activity of muscle, a problem of TNJ. I need the help of the osteopathist or the physio. Is possible. Well, we record a new position. The technician prepared for us waxing that we applied in mock-up protocol on the patient. And the mock-up immediately show me a different distribution of forces. Immediately I can see that the posterior teeth contact have a good interscopation, and finally I have a good distribution of forces in the mouth. So anterior area, the anterior teeth are protected, and I can send the patient to her clinician, telling him work in this position and use my mock-up to prepare your new treatment plan for a prosthodontic treatment for this patient. Another interesting case for an important patient in which my partner and me, we did so much of things, surgery and laminate veneers and crown veneers and endodontic treatment, because the need of the patient were different. Aesthetic, obviously, but also functional. because it's not easy to give to the patient a good aesthetic without to correct, for example, the curve of the occlusal plane or the anterior and lateral guidance. And we can, to avoid overloading in a so important therapy, we check activity of muscle with electromyography, and we check the importance and the quantity of the load on the entire arch with OccluSense in static and dynamic recording. So when our technician prepare for us the waxing to apply on the patient with mock-up protocol, you can see here the fantastic work of Luca Vailati, our technician, one of our technicians. I want to be sure that this mock-up is not only beauty to see, but also that it works correctly with a good muscular activity, but also with a good distribution of forces in the mouth. Electromyography shows us that the activity of muscle is improved. They are more balanced in the new position. So the pre and post situation with the mock-up that became also a speed up to prepare our laminate veneers is correct. So we can apply provisional work, and also we have to check during the therapy if our provisional don't are abraxed or damaged. This is really useful to check forces, because sometimes when we apply our final therapy, the patient is in perfect comfort, so the patient can grind and can eat and can use the therapy as obviously natural teeth. And after 50 years, we see a different situation of point of contact, And please get a look to this first lower right premolar. Here, I can see with occlusal paper after 5 years precocity. Why? I don't know. I can check it with occlusal paper, and remember, I love those occlusal paper pre-mounted on a support. 12 microns, black and red colors on an aluminum, very thin surface. Those are fantastic. You cannot damage it using, because they are very hard, but very thin, very comfortable to use. You can use both the papers to check the entire occlusion, or on a side, only one paper. But also, obviously, we have to check forces with OccluSense. You can see here the papers is fantastic, because I can, after I use the papers, I can check where are the silver sign here, where the paper is damaged. I can see where is the load. Well, this is the arch of the patient with the 12 thickness of the paper. Here, really, really evident an excess of precocity of contact with an excess of load, and the other teeth are not in contact. If you use to check this situation an excess of thickness of the paper, is possible you don't see you don't see the lack of contact, because if the thickness is high, for example 200, you see the contact also in the posterior teeth. They don't touch, but you can see force contact. So use a thin occlusal paper to check the precocity. It's here only one tooth touch in this patient. Why? Because the situation at the end of therapy were not this, but the patient have a new position because using the teeth and in his life also he can have some trauma, new position at the work. Well, the position of the jaw can change, and it's possible the mandible move. So I have no a real contact in the posterior teeth, only on the premolar. We check it, it's really evident. The blue sign are with the 65 microns paper, but the black sign is with the 12 microns paper. So you can see if you use only 65, you cannot find the precocity because the posterior teeth pretend they are in contact. It's not true. Well, it's possible to progressively touch and grind the contact more and more. Here until the 8 microns paper is locked into the teeth. But also the support of OccluSense is essential. You can see here, before to correct the contacts, only one precocity on the first molar, premolar, here. When we touch the premolar, immediately appear posterior contacts. And we go again, go away to touch with the gums, grind and grind and grind slowly until we find a more distributed contact in the mouth. But also here I have again a little excess of load. So never without. A last clinical case, also prepared by the therapy is from my super partner, Christian Corraini, important abraxed occlusion on an old patient with different needs in his mouth. We need to prepare in a preliminary phase a functional occlusion that can provide useful guidance on the possible tolerance of an increasing of DVO. So we prepared a customized device, I mean a splint, to check the new position. You can see some history of electromyography because in the past we used the raw signal to check the patient. Today we don't use more this instrumentation that has been the basis of electromyography. Today is easier to use different issues and skills. This is a simple lower splint to check the new vertical position, to ask the patient if he's in comfort, and to check if the muscular activity with electromyography is good. And it is good. And then I go to the final restoration. This is the final restoration. And now, looking at the picture, we can see an interference here on the second molar upper right of the patient, upper left of the patient, in the lateral right-sided guidance. I don't want to see this red mark here. It's dangerous. And if you see this is the upper arch, lower arch. Well, a fantastic work, the patient is happy, but we have also a different ability to move before and after the therapy, because during the therapy, the patient has allowed to learn new ability to move the jaw. Well, before and after, but after some years, after about 10 years, we see the patient have a different occlusion. We have some surprise. Anterior teeth are damaged. Some sign in the interior part, palatal part of the upper teeth, and the lower teeth are damaged, are overloaded. Some precocity in different areas, and the muscular activity is not perfect. The patient is in health, but his muscular activity is not correct. So I ask to the patient to chew a gum or to do some training to improve his chewing activity that is not balanced with an excess of work of the right masseter and a low work of the left masseter. It's not possible to balance correctly a patient that has an unbalanced chewing activity. So all our work can be damaged in some years of unbalanced activity of muscle. This is a resume of the work, and 2013 e 2021, after 8 years, this is the situation. Excess of load, grinded teeth that can be obviously restored, why not? Erosion, chipping on ceramic, also lingual erosion. We check the Brooks checker, and we can overlap. The old Brooks checker did 9 years ago, and the new Brooks checker. Today, we don't find so much of grinding activity. And what about the forces on occlusion? Well, a little excess on the posterior right area here, obviously also on the posterior left area over there. The position is not the same of 9 years ago. The mouth changes. And we work until we find a correct lateral guidance without interference. Look at here. I don't want to see this little sign in right lateral guidance. I want to grind it. And also in the anterior movement, I don't want to find the forces on the posterior area. So immediately and gently, we grind it and balance. This is the new OccluSense, the new Brooks checker. It don't show us any area of excess of work. And then we check also the activity of the splint that have to be balanced. So the common protocol suggested is to before, check forces with OccluSense. Then see where are the point of contacts with occlusal pepper. Finally, again, check forces with OccluSense. Sometimes you can check forces immediately with the occlusal pepper, but ever check the balanced occlusion with OccluSense. Or you will don't know how are strong the forces on occlusion. So remember it. Check premature contact, adjust occlusion with occlusal pepper, control occlusion. Remember it. Well, so much of people use OccluSense in the world. Just yesterday, I had a fantastic meeting online with incredible and fantastic colleagues from India, Brazil, Germany, Lebanon, Egypt, and in all the world, the people want to measure and check occlusal forces. It's useful. It's useful in my daily practice. Really, chairside the instrument is really ready to use for me. And also my partner and me in our clinic, for us it's usual to use, never without. And in our learning activity, education, and thank you to Bausch and Dr. Zulaika to help us to in our lessons, we show how to check occlusion with OccluSense. You only need an iPad and the instrument, no more. You can use also old iPad, not new. You have to use an iPad produced on 214 or leather. You have to download the app for the iPad, and you have to buy the instrument with some sensors, large and small. Thank you for your attention. I hope you enjoyed the lessons, and I hope to see you in a last opportunity to meet together.